Good morning, everybody, and welcome back to American Safety Programs and Training, Chapter Review, Chapter 20 for Immunologic Emergencies. So, immunologic emergencies. What is that talking about? The subject matter is immunology. It's the study of the body's immune system. The body's immune system is charged with protecting the human body from any outside substances or organisms that are foreign to our body. Bacteria, viruses. If it doesn't belong in our body, our immune system fights after it. One of the ways it does it is that, as you know, blood is made out of four components: red blood cells, white blood cells, platelets, and plasma. The white blood cells, when it senses an infection in the body, it sends the white blood cells to fight the infection. That's part of the immune system, along with many other parts and systems in the body. So let's start off with, first of all, let me start off with, I hope everybody's staying safe. I hope everybody's practicing your social distancing. If you guys have access to them, make sure when you walk out of the house, you go to the store, you go for a walk around the block, make sure you're wearing your masks so you stay safe. Okay? So it's very common for EMTs to respond to a 911 call for an allergic reaction. Allergy-related emergencies may involve an acute airway obstruction, which is a partial airway obstruction, or a complete airway obstruction, or cardiovascular collapse because of the allergy, because of the body's reaction to the outside allergen. As an EMT, we have to be able to treat these life-threatening complications, and we have to be able to distinguish between the body's usual response to an allergen and an allergic reaction. We need to be able to identify the signs and symptoms of somebody who's in anaphylactic shock, and we need to determine the level of that reaction. Is it severe, where the patient's life is in jeopardy, or is it a mild reaction where they might have some hives, a little bit of lightheadedness, maybe a little bit of shortness of breath, but not much, not enough to raise a red flag to say this person needs to get to the hospital emergency right away, or their life's in danger, or they have redness and itching on the skin, or it could be on the opposite end of the scale where they're not breathing or they can barely breathe, and anywhere in between. So it's our job to be able to try to determine that. And decide what we're going to do. The anatomy and physiology. The immune system is designed to protect the body from any foreign substances and organisms. When a foreign substance or body invades our body goes on high alert, and the body initiates a series of responses to inactivate the invader, to basically go after and kill the invader, to nullify it, kill it, and get it out of the body as quickly as we possibly can. So, what is an allergic reaction? An allergic reaction is basically an exaggerated immune response to any substance. It's not caused directly by an outside stimulus. And a lot of people say, what? That doesn't make any sense. But it is caused by the body's immune system. When the body reacts to an outside stimulus or an outside foreign body, it releases chemicals to combat the stimulus. Okay, so let's go back to the beginning. An allergic reaction is an exaggerated immune response to any substance. Our body, when it is exposed to an outside stimulus, that it's never been exposed to before, that it's never had to deal with before, sometimes it doesn't react. Sometimes it does. And when it does, it might be a mild reaction, some hives, some itching, some redness, or it might be a severe reaction where the person can't breathe. The muscles in the airway are closing and the blood vessels are dilating to pump a lot more blood to get the white blood cells to the area where the invader came in. The body's immune system goes into overdrive, it goes into an exaggerated or ridiculously over response. It goes to deal with the invader, but in the process of doing that, it overreacts. And in the process of overreacting, it almost kills us. And those are times when it's severe anaphylactic shock. Okay? Sometimes the body can deal with the substance, and sometimes it can't. Everybody's different. Some people are allergic to peanuts and seafood. Some people are allergic to just peanuts or to just seafood. Or some people are allergic to hay fever. Some people might be allergic to pollen. Everybody's different as to what they're allergic to. And some people are not allergic to that many things to begin with. And other people are allergic to a lot of different things. And when those people who are allergic to something are exposed to that product or to that item that they're allergic to, how the body responds to it all depends on how the body just wants to naturally respond to it. Sometimes it'll respond to it very carefully, very slightly, and other times it goes into overdrive and it over-exaggerates the invader, and it almost kills us. And that's what and that's when we're dealing with anaphylactic shock. Not caused directly by an outside stimulus. Well, that's sort of confusing because it's the outside stimulus. How can I say it? Prime example. You're allergic to bee stings. Okay? So a bee comes along, it stings you, and you start having a massive reaction. You start getting lightheaded, nausea, severe itching, redness, burning at the stinging site, and you start having difficulty breathing. Okay? It's not the stinger. It's not the act of the outside stimulus, which is the bee's stinger. Because the bee's stinger is a hollow tube that has barbed wires on it, sort of like a fish hook. It goes in very easily, but you can't take it out. And when the bee flies away, you have this little bag of venom that's still connected to the stinger, and that stinger is still in your skin, and it's still pumping the venom into your body. When that venom goes into your body, that's called vemination. When an ant bites you and it injects some venom, that's envenomation. When a bee stings you, that's what happens. When bees sting you, they leave the stinger behind with the sac, and it keeps pulsating and keeps injecting the liquid into, or the venom into your body. Whereas wasps and hornets, their stingers don't come out of their bodies. They just sting you repeatedly. And with every sting, they give you some venom. So what happens is it's the venom that's going into your body that is the outside stimulus entering your body, and it's your body's overreaction, or it's your body's reaction to that venom that's coming into your body that causes the anaphylactic shock, okay, or it causes the body's immune system to kick into overdrive. Now, the third one, caused by the body's immune system, releases chemicals to combat the stimulus. That's exactly what it does. There's two common, there's two chemicals that the body releases to fight that, and those two chemicals are called histamines and leukotrienes. That's page 753. Okay? Histamines and leukotrienes are the two chemicals that are released by the body which actually contribute to the anaphylactic reaction. So, we already talked about what the allergen is. Okay? The allergen is the outside stimulus that comes in to your body, and your body starts to go after it. Okay? And as I said, the allergic reaction may be mild and local. It can be characterized by redness and itchiness and tenderness, or it might be really severe and symptomatic. And when it's severe and symptomatic and other systems in the body starts getting affected, then that's what we call anaphylactic or anaphylaxis. Okay? Now, the two most common signs of someone being in anaphylactic shock is urticaria and angioedema. Okay? I'll go to the next one here. Might be getting a little bit ahead of myself here. Okay? Urticaria is when you get small hives in small areas of generalized itching and burning that can appear as multiple small raised areas on the skin, so like a bunch of little pimples. But they could be wider. Okay? They could be a little bit bigger, diameter-wise. And angioedema is just basically swelling, localized swelling of certain parts of the body. Some people, and I don't know the medical breakdown of it, sometimes when people have anaphylactic shock to something, their tongue swells. And it swells to the point where they can't even breathe because the tongue swells to 10 times its size. And it's really, really weird to see. But let's see if we can get to this. Some patients may not know what is causing the reaction. Yeah, sometimes they may have eaten something that they're allergic to, and they had no idea that they were allergic to that particular food. Now they're starting to have a reaction. It might be mild, it might be major. They don't know. But we need to be able to recognize the signs and symptoms and maintain a high index of suspicion as to what could be causing the patient's problems. Okay? And there's a way we can get around to that, and I'll get to that in a little while. Allergic reaction may be mild or local or severe and symptomatic. Okay, so anaphylaxis is an extreme life-threatening allergic reaction. It involves multiple organs and systems, and it can rapidly result in shock and death. If we do not identify that the person is in an anaphylactic reaction, and if it's mild or major, especially if it's major, we need to be able to identify that and to be able to react and treat it very quickly, because a lot of people, the majority of people, I want to say it's maybe like 30%. I'm sorry, most people who pass away from a severe anaphylactic reaction will pass away, I want to say, within the first 30 minutes of when the reaction begins, because it's not treated, it's not recognized and treated quick enough. The quicker we recognize it, the quicker we treat it, the quicker or better chance the patient has of surviving the situation. Same thing with cardiac arrest. Early recognition, early activation of the 911 system, and early CPR and AED usage. Okay, early recognition, trying to determine what's going on. They call us on 911, we get there, it's our job to figure out what's going on as best we possibly can. 3 common signs of anaphylaxis, like I said: urticaria, which are hives, the top right there. And what these are actually called, these little bumps, these little hives, if you want to call it, when they're a little bit bigger like that, if you can see where my arrow is pointing, that's called a wheal. Okay? It's a little bit round, but that's called a wheal as well. Angioedema, right there in the bottom corner where the lady's tongue is extremely swollen, that's like 10 times the size. You can see she would not be able to breathe through her mouth at all. She would only be able to breathe through her nose. So that's pretty scary. And wheezing. Wheezing is when you have swelling of the upper respiratory, or the upper airway. Patients may also experience hypotension due to vasodilation and increased capillary permeability, and gastrointestinal dysfunction. In other words, they're nauseous, they're vomiting, and they have abdominal cramps. Hypotension due to vasodilation. Hypotension is when the person becomes very lethargic. They become almost like they want to pass out, like they're becoming really, really tired. Vasodilation is when the blood vessels, the arteries and veins, they dilate. They get really, really big because the body says, oh, we're having an anaphylactic reaction to something, or we're having a reaction to something, so I need to protect the body. So in the immune system's way of thinking of protecting the body, it's going to take the muscles of the airway and it's going to start tightening them. In the process, it thinks it's doing something good, when in fact it's doing something really bad because it's making it more difficult for us to breathe. But it thinks it's protecting the body by reducing the airway, restricting the possibility of anything else getting into the body through the lungs. Vasodilation occurs because your airway is reduced in diameter. Your body says, whoa, we're not getting that much oxygen, we're not getting that much air, so now we got to start pumping more blood to make up for it, because we need to make up for that difference in oxygen that the lungs aren't getting. So it's going to start pumping faster, harder, and it's going to dilate all the veins and arteries in the body so it can pump that extra volume of blood. In the process of doing that, you start to lose consciousness. You start becoming lightheaded because it happens so quickly. Common allergies Food, medications, plants, chemicals, and insect bites and stings. Insect bite and stings are the most common ones, and so is food. And they're all common, but a lot of ones we're going to deal with are those. Food, a food allergy. Y'all know about that. Peanuts, seafood. Sometimes symptoms can take up to 30 minutes to show up. The most two common ones are shellfish and nuts. Usually my experience has been when someone has an allergy to shellfish and nuts, it doesn't take 30 minutes for the signs and symptoms to show up. They start to show up pretty darn quick, within minutes, if not maybe 2 or 3 minutes at the most. Okay? But it could also be somebody's allergic. As you get older, your body changes, and it could be that you could have a mild reaction to certain seafood. You can eat fish, but you can't eat shellfish. There's something about shellfish that doesn't agree with your body. Why? Who knows? You might have a minor reaction to it. You might have a major reaction to it. Peanut butter and jelly. Okay, or you might have an allergy to carrots. Who knows? I mean, everybody's different. All depends on the amount of time it takes for the signs and symptoms to show up. All depends on how your body determines the threat of that allergen that's coming into your body, and whether your body determines it as a major threat or a minor threat. If it considers it a minor threat, the reaction is probably not going to be that bad. But if it considers it a major threat, then it's going to start doing some massive attacking of that product coming into your body. Medication. If medication is injected, the reaction may be immediate and severe because it goes directly into your bloodstream, and reactions to oral medications may take more than 30 minutes to appear. The reason being is that oral medications, if it's a tablet or a pill or a capsule or liquid, it doesn't get ingested into the human body until it enters your intestines. So it takes 30 minutes for that medication to go and start to be absorbed into your body. Plants, such as dust, pollens, and other plant materials, ragweed, ryegrass, maple, or oak. Okay, you breathe that in during the summertime or during the fall when leaves start to fall. That's when pollen's very, very popular. Chemicals, certain makeups, soaps, or hair dyes, certain chemicals are in these products that you're allergic to. A lot of people are allergic to latex. Very, very common. So now we use nitro gloves that doesn't have latex in them. Insect bites and stings. Envenomation is what I said. It's like the process of an insect injecting its venom. Okay, and then the reaction may be localized or systemic. Localized meaning it just might stay where the bite took place, and systemic means it's causing other body systems and organs to be affected. Insect stings, approximately 3% of adults and 1% of children are allergic to the venom of bees, wasps, and hornets. I don't like those things to begin with, so I don't want them anywhere near me. Insect stings cause at least 50 deaths per year in the U.S., and the stinging organ of most insects is the small hollow spine projecting from the abdomen of the insect. And best example of that would be the bee. When the bee stings you. Honeybees cannot withdraw their stinger; it stays in you. And wasps and hornets can sting multiple times. Some ants, especially fire ants, strike repeatedly, and from what I've heard, the bite from a fire ant is extremely, extremely painful. Signs and symptoms: sudden pain, swelling, localized heat, urticaria, which is the raised bumps on your skin where it took place, or throughout your body, redness in light-skinned individuals. Okay, so you're gonna have it's gonna be very, very red, and itching and a wheal, WHEAL. That raised part, if you can see, it looks like right there, that little red part, that looks like where the person was stung at, and that area around the sting or in the general vicinity of where the sting or the bite took place, that skin is actually raised up a little bit. That's called a wheal. In severe anaphylactic cases, patients may experience bronchospasm and wheezing, chest tightness and coughing, dyspnea, anxiety, gastrointestinal complaints, and hypotension. So we talked about those. The hypotension comes about because of vasodilation. The gastro complaints, your body's just your body's way of trying to protect itself. anxiety, difficulty breathing, okay, difficulty talking, saying that many words in one sentence, chest tightness and coughing, okay, and bronchospasms and wheezing. Let's see here. Make sure I'm covering everything for you. Okay, common allergies. And patients may occasionally experience respiratory failure if the patient is having a massive anaphylactic reaction to the item that's making them sick. They can't stop breathing. If it is untreated, an anaphylactic reaction can proceed rapidly to death, very, very quickly. If we don't identify it and treat it very quickly, that person can and will pass away. Okay, so let me go back some of the common allergies. We talked about the food, seafood and peanuts, medications. Somebody could be allergic to medication, whether it's a prescription that the doctor gave them, whether it's an over-the-counter medication that they buy at CVS, or what is one of these, what do they call that? It's all natural, holistic medications. Okay? It could be now the prescription that the doctor gives their patient. Well, shouldn't the doctor know that this patient of theirs, who's been their patient for the past 25 years, is allergic to this medication? Well, not necessarily. If the patient's never been on that medication before, the doctor may not know. If the patient's never been on a medication that is in the same drug class of this medication, then the doctor wouldn't know. But it could also be, and I think I discussed with you guys before in a prior chapter, if a patient goes to more than one doctor, they should be using one pharmacy. They shouldn't be using 2 or 3 different pharmacies, or even 2 pharmacies, because not all pharmacies share databases. If one person goes to CVS and then that same person goes to Rite Aid, and then that same person goes to Walmart's pharmacy, those are 3 different pharmacies. Pharmacy 1 and Pharmacy 2 don't know what the patient's on. They rely on the patient to tell them what other medications they're taking. Okay? And the doctor relies on the patient to tell them, okay, well, doc, 2 weeks ago, my cardiologist gave me this medication for my blood pressure. So if the patient is seeing multiple doctors, they go to multiple pharmacies, and they get different medications, part of a pharmacist's job is to identify a bad reaction that 2 medications are not supposed to be taken at the same time. Well, if they're not getting the medications from the same pharmacy, then how's the pharmacist supposed to know that Dr. 1 and Dr. 2 and Dr. 3 prescribe these medications? So the person could be having a reaction to medication because the medications aren't supposed to go together, or they have a bad side effect. And this happens because they don't get their medication at the same pharmacy. It could be that the patient just doesn't have a good reaction to the medication. The doctor just changed their medication because the insurance company no longer pays for a tier 1. Now they're going to pay for a generic of that medication. And the patient takes the medication once a day, and maybe it takes a week or a couple of days for the side effects to start showing up of that medication. And you're going to determine that when you're doing your sample and your OPQRST with the patient, when you talk to them about medications, any current medications, medication changes. Do you have a list of your medications? Where are your medication bottles? And you write them all down on the report. Okay. Over-the-counter, same thing. You don't know if an over-the-counter medication is going to react with another over-the-counter medication, or it's going to react badly to a prescribed medication. So that's why it's very important that the patients need to tell their doctors and their pharmacists all medications that they're taking if they're going to multiple providers. We talked about the environmental ones, the pollen, the hay fever. We talked about the plants, the ragweed and mold. What about chemicals? Okay, latex and soap. Could be cleaning chemicals at the house. Maybe there's one certain type of dish soap you can't use, or maybe there's a certain type of dusting chemical you can't use. Say you're allergic to Murphy's oil soap for some reason, or you can't use Spick and Span. And then bug bites and stingers. We talked about the envenomation, and that they put toxin into your body, and the toxins are considered poisonous by the body, and the body goes after it, it attacks it, it fights it, and sometimes in the process of doing it, the immune system way over exaggerates its response, and the response really doesn't have to be as strongly as it's making it, and that can actually kill you in the process as well. Okay. Okay, that's what it was. 2/3. 2/3 of the people who end up dying in the U.S. from anaphylactic shock usually die within the first 30 minutes. 2/3. Okay? So say you have 90 people who have a severe anaphylactic shock, and out of those 90 people, on average, 2/3 of those people will die if it's not treated within the first 30 minutes. It doesn't necessarily mean that 60 out of 90 people are going to die every single time. No. On average, 60%, which is 2/3 of those 90 people, could pass away if that anaphylactic shock is not treated within 30 minutes. So, what do you want to do? You show up on scene, you call to somebody's house, 25-year-old male, backyard, celebrating their child's 5th birthday party, and difficulty breathing. That's all you know. Dispatch tells you, 25-year-old male at 352 Main Street, difficulty breathing. So you show up, bunch of kids, bunch of parents in the backyard, there's a guy on the ground, looks like he's having a hard time breathing. Okay? Scene size up. Okay? First thing, scene size is the first category of your patient assessment, either medical or trauma. Scene safety. Okay? Number of patients, MOI, NOI. Additional resources. Consider C-spine stabilization. Is the patient's environment or recent activity may indicate the source of the allergic reaction. Difficulty breathing, you walk in the backyard and the guy's standing, or he's on the ground 5 feet from like 3 beehives because he likes to raise his own bees. You think that might be a possibility? Or there's a hornet's nest above the porch, up in the wall or up in the ceiling. Could it be you're showing up at a restaurant and there's food on the table and it looks like the person was eating seafood? You know, you never know. Keep your eyes open. Scene safety. Be mindful of other potential causes of respiratory distress. What else could have caused it? You don't know. I mean, you don't know that much showing up to scene. Just is other than difficulty breathing. Okay, but look around you. What's going on? If you show up on scene and you walk in and the person's on the floor in their living room or their bedroom, do you see empty alcohol bottles all over the place? Do you see used syringes in the general area? Do you see a bunch of medicine pills on the nightstand or on the coffee table or on the ground next to the patient? Okay, could they have taken a medication? Could they have overdosed? Okay, that'd be something completely different. Or could they have taken a new medication and they're having a bad reaction to it? Okay, consider the need for additional resources such as advanced life support. There's nothing wrong with ever wanting additional ALS or EMTs on scene, especially ALS. Quickly identify and treat any immediate or potential life threats. And what are the 2 life threats we taught you guys about them in your patient assessment? Okay, that's in your primary assessment. Bleeding and breathing. If the person's having a difficulty breathing, you address it very quickly, as fast as you possibly can. If they're not breathing correctly, that means that they have poor perfusion, which means that they're going into shock. And what do we do for every person that's in shock? High flow O2, position of comfort, keep them warm and rapid transport to the hospital, right? Okay, so with this, difficulty breathing, you're going to get high flow oxygen to the person. Are you going to do that by a nasal cannula? Are you going to do it by BVM? Or are you going to do it by a non-rebreather? How much oxygen are you going to give them? What's the saturation level of such? Okay, we know that when you use a BVM, you're going to breathe for the patient. You're going to breathe what, every 5 to 6 seconds, 1 breath? How do you know you're giving a good breath to that patient? When you get equal and bilateral chest rise. When you see the chest rise on both sides equally, that's a signal that you're giving a good breath. Make sure you do a head tilt chin lift. Open up and secure that airway. Okay? Put in OPA or NPA if you need to. High flow O2, 15 liters per minute. one breath every 5 to 6 seconds with the BVM. Let's see. Okay, form a general impression. May present as respiratory or cardiovascular distress in the form of shock. Patients will often appear very anxious, and they're appearing very anxious because they're having a hard time breathing. They can't catch their breath. They get very, very scared. Look for a medical identification tag. Do they have one on their wrist? Do they have around their neck? Are they a diabetic? Does it say anything that they're allergic to? Ideally, people who have medical alert bracelets, it'll tell you what their medical condition is. Okay? Airway and breathing. Anaphylaxis can cause rapid swelling of the upper airway. Work quickly to determine the severity of the symptoms. How bad are they having a hard time breathing? Can they sit up in the tripod position on the edge of the chair with their back straight up, one hand on each one of the top of their knees, and they're lifting their chin up in the air, and they're trying to open that airway from the mouth all the way down the lungs to try to make it as straight as possible? Or are they having such a hard time breathing, no matter what position that they're in, that they're having a hard time breathing, and you're hearing wheezing, like, I can't breathe. Okay. So what do you do in a situation like that? You need to quickly assess for increased work of breathing. You're going to look for the use of any accessory muscles. Is their head bobbing, like they're about to fall asleep? That's head bobbing. Are they sitting in the tripod position? Are their nostrils flaring? Okay. And abnormal breath sounds. It just doesn't sound right. Airway breathing continued. Assist the patient into a comfortable position to maximize ventilations. If signs of shock emerge, place the patient in the supine position, which is down on their back, and provide high flow O2. In severe situations, assist ventilations. And the old saying we used to say, less than 8, more than 28. If they're breathing 8 times a minute or less, you need to breathe for them. If they're breathing 28 times a minute or faster, you need to breathe for them. Because what's the normal respiratory rate for a person? Okay, if they're too low or if they're too slow or too fast, then you need to breathe for that person. Okay, so you're going to initiate high flow O2 either with a non-rebreather 15 liters per minute, which is considered high flow, and that's 80 to 90% oxygen saturation, or if you have to, you're going to breathe for them with the BVM, with the reservoir, high flow O2, 15 liters per minute, and that saturation is 90 to 100%. Circulation. Patients may present with hypotension, which is poor perfusion. Hypoperfusion. Okay. Treat for shock. High flow O2, which you're already doing. Get the person in a position of comfort. Keep them warm with a blanket if you can, and rapid transport to the hospital. Okay. The definitive treatment for anaphylactic shock is epinephrine, otherwise called epi. Okay. We'll talk about epi in just a second. Transport decision you need to make. Okay. So after you've done your scene size up, then you've done your primary survey, what's your general impression of the patient, you determine level of consciousness, that's the stuff we all just talked about. Can they talk? If they are, do they know where they are, who they are, what time of the day or week or month it is? Okay, person, place, time, and event. Do they know what happened? A lot of times if you get there quick enough, they can tell you, yeah, I'm allergic, I can't find my EpiPen, I'm allergic to bee stings, and the damn bee just stung me on the back. Okay, how bad's your reaction? It's usually really, really bad. That's why my doctor gave me an EpiPen. Anybody who's prescribed an EpiPen by their doctor, that means that they have a severe reaction. Okay, so you need to be aware of that. Okay, so after you determine your level of consciousness, okay, then you start with the airway, breathing, circulation. Airway, we just talked about that. Make sure it's a patent airway. If it's not, you need to make it patent. How do you make it patent? With an OPA or an NPA? Okay, breathing. Are you going to breathe for the patient, or can they breathe on their own? What's the normal respiration rate for a patient? 12 to 20? Okay. If they're less than 8, you got to breathe for them. If they're more than 28, you got to breathe for them. And if you're going to breathe for them, what device are you going to use? A BVM or a non-rebreather? If you're going to breathe for them, you're going to have to use a BVM. But can you use a non-rebreather first? Will that be sufficient? Okay. And then circulation. Check their pulse. Do they have a strong pulse? Or do they have a weak pulse? If they have a weak pulse, then it could be going to hypoperfusion. It could be going into shock, and you treat for shock. Okay. At that point, after you've done your ABCs, you need to make a transport decision. Is this a scoop and screw, or is this a stay and play? If it's a scoop and screw, that means you basically need to get the patient in the back of the truck as quickly as possible and en route yourself to the hospital to definitive care because they're going to need it very quickly. Or if the patient's having a mild reaction and you can afford to stay on scene for a couple of extra minutes and consider other alternative treatments because you don't see a life threat right now. Okay? Always provide prompt transportation for any patient who may be having an allergic reaction. If the patient does not exhibit severe symptoms, consider continuing the assessment en route and err on the side of emergency transport. Anybody who calls you, who calls 911 because they're having a reaction to something, whether it's minor or major, they need to go to the hospital. You need to do everything you can to get them to go to the hospital because it could be that they're having a mild reaction and the big reaction could be 30 minutes down the road. Everybody's different. You don't know. Okay? You need to get every single patient to the hospital. History taking. Investigate the chief complaint. Why am I here? What's going on? Well, you're going to know the chief complaint as soon as you show up on scene. History of the present illness. Okay? What's going on? Has this ever happened before? Yes, it does. My doctor prescribed me an epi because I'm allergic to bee stings. Right away, the red flag and should go up, and the hair on the back of your neck should go up and say, whoa, right now you know it's an emergency situation. Identify the associated signs and symptoms. Look for the signs and symptoms. Do the signs and symptoms of someone in anaphylactic shock or just shock in general, do you see those? What's the difference between a sign and a symptom? A sign is something you see. A symptom is something the patient tells you. Okay? When you guys get a chance, take a look in your book, Table 20-1. That'll give you additional signs and symptoms for an allergic reaction. Okay? Doing your sample. Okay? Signs and symptoms, allergies, medications, past pertinent medical history, last time you had something to eat, and events leading up to. Signs and symptoms. Okay, what do you see? What does the patient tell you? Or what's their family member telling you? Allergies. Do you have any allergies? Yes, you have an allergy to what? To bees and seafood? Okay. M, medication. Do you take any medications? Yes, I take medication for high blood pressure because I'm fat and overweight. Okay, cool. P, past pertinent medical history. Yes, I have a history of bad reactions to bee stings and to seafood, so my doctor gave me an EpiPen. Okay, have you used your EpiPen yet? No, I haven't. My wife's looking for it right now. Okay. L, last oral intake. When was the last time you had something to eat? Where we're eating here in the picnic, and I started feeling bad about 10, 15 minutes ago. But I just finished eating a salad. That's all I had. I had a salad about 20 minutes ago. Okay. If they're allergic to bees and they're allergic to seafood, is anybody eating seafood at the picnic? Okay. Or are they inside a house? Okay. If somebody is eating seafood, could they have a seafood salad? And could the person who made the seafood salad and then made your patient's salad with grilled chicken on it, could there be any cross-contamination taking place? Okay, consider that. Or could it be a bee sting? Could it be an insect bite? If he's not complaining of a possible insect bite, then you have to think it's food. How could it be food related? Okay. Have any interventions already been completed? So you have an EpiPen. Did you take it yet? No, I haven't. Okay, where is it? My wife's looking for it. Okay. Has the patient experienced a severe allergic reaction in the past? In this case, yes, because that's why the doctor prescribed the guy to carry his own EpiPen with him. Be alert for any statements regarding ingestion of foods that might cause an allergic reaction. Just like I talked about seafood salad. Okay? Ask about gastrointestinal complaints, nausea or vomiting. Physical examination. Your secondary assessment. Your secondary assessment is designed to concentrate on the affected body part in the body system. And remember, there's 8 different body systems we need to investigate, or that we could investigate. Physical examination. Perform a systematic head-to-toe or focused assessment. Okay? You should have already done the focused assessment during your primary assessment, or what they call a rapid assessment, and then you're going to do a detailed or focused, a very, very focused, very detailed assessment during your secondary assessment. Auscultate, which means listen for the breath sounds. Get out your stethoscope Checking the areas where we taught you how to listen for your lung sounds. In the front is going to be mid-clavicular. Okay, it's going to be directly, then you could draw a straight line down under the nipples, directly under the nipples. Okay, and then mid-axillary, which is up in the armpits. And you're going to check in 6 areas in the back, starting at the top and working your way down. Top of the lungs, middle of the lungs, bottom of the lungs. Okay, inspect the skin. Are there any wheals? Are there any rashes? Any redness? Assess baseline vital signs, blood pressure, pulse, respirations, blood glucose level. Okay, check your eyes. Don't forget fast, face, arm, speech, and time. Okay. Skin signs may be unreliable. Could be reliable, could be unreliable. Could be the guy's got a red patch on his arm or on his back, and it could be from acne, it could be something else. Ask the patient. Monitoring devices. Pulse oximetry can be a useful method to assess a patient's perfusion status. You want the pulse ox to be as close to 100% as possible. Once it gets down to 94, 95, 94, 93, that's not good. You need to get them oxygen right away. Decision to apply oxygen should be based on the airway patency. Is it secure? Is it a patent airway, yes or no? If it's not, make it patent, OPA or NPA. Work of breathing. Is the patient breathing normally, or does it look like they have to fight to breathe in or fight to breathe out? And when you listen for lung sounds, do you hear anything that sounds weird? Do you hear Rice Krispies in the base of the lungs? Do you hear when the patient breathes in or breathe out? Do you hear any wheezing or stridor? Okay. And you want to reassess the patient. Okay. Stable patient, you reassess every 15 minutes. Unstable patient, every 5 minutes. If you want to reassess your patient every 10 minutes, that's fine. You can never go wrong reassessing your patient. Don't ever take your eye off the patient. Don't sit behind the patient in the jump seat. Make sure that while you're transferring the patient, you're on the bench seat, sitting right alongside the patient, keeping your eye on the patient for the entire time during transport. You can work on some of your report while talking with the patient. Okay, if this patient starts having signs of shock or they start to decline, you're going to see it right away because you're going to see their body posture, you're going to see their face. Okay, and you're also going to hear it when you're talking to them. Are they responding to you as well and talking to you as well as they were 10, 15 minutes ago? It's a 20-minute ride to the hospital. You got 10 minutes to go, and all of a sudden the patient's barely talking to you. It seems like they're having a harder time breathing. So are they declining? Is there any trending going downwards? Interventions. What type of interventions do you want to take? Determine the severity of the reaction. Milder reactions require supportive care and monitoring. Anaphylaxis requires epinephrine and ventilatory support. And recheck your interventions to make sure that they're working. Communication and documentation. Documentation should include signs and symptoms, reasons why you chose to provide the care you did, and the patient's response to the treatment. Okay? Epinephrine. There's a drug that we can give the patient in the field that's called epinephrine. Every municipality or every business or every city and state have different protocols. You need to be familiar with the protocols of the state and the city that you will be working in. In the state of Rhode Island, we are actually allowed to give a patient an EpiPen. If you have the patient's EpiPen, you can use theirs. But you've got to make sure that you do the 5 R's before you use the patient's EpiPen. You need to make sure that it's the right patient, the right medication, the right time, the right route, and the right documentation. Okay? If you have to use your EpiPen, make sure that you're using the correct dose. With adults, you're going to use 0.30, and with children, you're going to use half of that, which is 0.15. Now, adult EpiPens are yellow. Children EpiPens are green. They either come in single packs or dual packs. Usually the best way for patients to buy them are going to be in dual packs, because if one shot of Epi doesn't work, then you always have a second one. Okay? But epinephrine. Epinephrine is a drug. It's a simple pathogenic hormone, and it basically mimics the sympathetic nervous response system, or the sympathetic response system in our body. Okay? What epinephrine does is when you give Epi to a patient in severe anaphylactic shock, remember what I told you when your body starts to go into anaphylactic shock, it tightens the muscles of the airway and it gives you bronchospasms, and it starts to decrease the diameter of the airway, making it more difficult to breathe. But it takes the arteries and the veins and it widens them, it dilates them. What epinephrine does is epinephrine reverses all of that. Okay? When you give epinephrine, it takes the muscles of the airway and it relaxes them. So instead of squeezing your airway closed, those muscles relax and your airway opens up, making it much easier to breathe. And then it goes to the arteries and veins, and when they dilated, it actually constricts them and makes them a little bit smaller. Okay, making blood flow throughout the body more efficient. So remember that. Epinephrine dilates and relaxes the smooth muscles in the airway, but it constricts the arteries and the veins. Because when somebody is having an anaphylactic reaction to something, the body's immune system, thinking that it's protecting the body, constricts the airway and it dilates the veins and arteries. Well, that's hurting you. It should be doing the opposite. So we give them epinephrine via EpiPen, and that dilates and relaxes the smooth muscle of the airway, and it constricts the arteries and the veins. Okay? Discussing an epinephrine. They have a picture of it here. Okay, so an EpiPen. When you administer an EpiPen to somebody, an epinephrine pen is designed to be given on the outside thigh. What you do is that an EpiPen has a long needle in it, and the medicine that's in it is under pressure, and it's spring activated. So what you need to do is you need to take the EpiPen and gently but firmly sort of slam it up. I shouldn't say slam, but with a little bit of force, put it against their outer thigh and push. What that does is that activates the spring inside. It ejects the needle into the person's thigh very forcefully, and it's a good sized needle too. It's not a skinny little needle, and it automatically injects the medicine into the person's thigh. You have to hold this device in place up against the thigh for 10 seconds. So when you put it on somebody and you push, you're going to hear a click, and that click is the needle being activated and being pushed out into the skin, and you hold it in place for 10 seconds. You can count out loud. You go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You take the EpiPen away. You're going to see the needle sticking there. Hand it off to your partner or put it in your sharps container, put it in your biohazard container. Then you're going to take your hand at a 2x2 or a gauze, and the injection site where you push the EpiPen up against the body, you're going to push and you're going to rub. You're going to massage that area for an additional 10 seconds. All that medicine, and it's a lot of medicine that gets pushed into the body, is sitting there and being absorbed into the muscles. That happens very, very quickly. You want to speed that process up, and you just put your hand there and you rub the injection site for 10 seconds in a circular motion. A couple times in clockwise and counterclockwise, up and down, left and right. You want to massage that area. That helps the medicine spread out into the muscles of the injection site and gets absorbed even quicker. Now, the epinephrine pen is designed to be safe. You just can't pick it up and hit somebody with it and the needle's going to come out. It has a top of it, or has a top on it that has to be removed first. So this is a training epinephrine pen. That's a training pen. Take a look at the bottom. It's a blue. Okay, that's the safety cap that has to be removed. The orange part is what goes up against the patient's body. So what you need to do is you need to take the safety cap off, and now this is live. It can be used. What you want to do, I'm going to use my desk as the patient's skin. You're going to take this, and some people hold it like this. You're not supposed to, because if someone's not paying attention and they're holding it like this, the needle's going to go into my hand. You should always hold an EpiPen either like this, or you should hold it like you're going to hold a dagger, like this, so that none of your extremities are on the end. You take it and you push it up against the person's body, and you hold and you count to 10. Listen. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You take it away, hand it to your partner, and then rub the area that you administer the medication in. circular, counter circle, up and down, left and right. And that's how you administer epinephrine. Again, adults are yellow and children are green. That's how you can tell. It'll also tell you the strength of the dose on the EpiPen as well. Okay. If patient appears to be having a severe anaphylactic reaction, administer basic life support and provide prompt transport to the hospital. If the person was stung by a type of animal where the stinger is still in place, a honeybee, a bee, you don't go with a pair of tweezers, or you don't grab it, find it, grab it, and then pinch it out. Because when you do that, then you're taking all the venom that's in the bag and you're going to squeeze it with tweezers or your fingers. You're going to squeeze all that venom right into the person's body. Take a credit card or a business card or a couple dollar bills, fold it in half, and you want to scrape. So like when you're taking scales off a fish, you want to scrape that out or scrape it out of the body. Do not use tweezers or forceps. Okay? Be alert for signs of airway swelling and other signs of anaphylaxis. Place a patient in the supine position and give oxygen as needed, and monitor their vitals. Okay, here we go. Epinephrine mimics the sympathetic fight or flight response. Rapidly reverse the effects of anaphylaxis, and it does that by opening up the airway and constricting the blood vessels. And if a person has a history of a severe anaphylactic reaction, they will have an EpiPen administered or prescribed by their doctor that comes pre-dosed in an epi injector, otherwise known as an EpiPen. And refer to local protocols or consult medical controls to what you should do. And there we go. I wish I had pictures of the kids too. But this is an EpiPen 2-pack. The adult epi delivers 0.3 milligrams of epinephrine. The infant or child delivers 0.15. Okay, so if you can remember the point, either 0.3 or just 0.30 or 0.3 milligrams. But remember that 0.3 milligrams of epi go to adults. And what's happened? So 30 cents. Okay. Either way, I remember when I was in EMT school, I couldn't remember 0.3, so I just made the 0.3. I go 0.30, 30 cents. And what's half of 30 cents? 15 cents. So it's either 0.3 or it's 0.30 milligrams of epinephrine. It's the exact same thing. Okay? Or in the infant, the system delivers 0.15 milligrams. So you see the 0.15, 15 cents, 30 cents. So I don't know if that'll help you, but that helped me when I was trying to remember all the stuff that I was trying to remember in EMT class. Side effects of epinephrine. It'll give you high blood pressure because it's constricting the blood vessels. It'll give you an increased pulse rate. It might give you a little bit of anxiety if you didn't already have anxiety before because you couldn't breathe. It might give you a cardiac arrhythmia, which means an abnormal heartbeat. Okay? May give you some pallor, some dizziness, a little bit of slight chest pain. Might give you a headache because the response is very quick. So your body going from low blood pressure and low pulse rate within a matter of seconds to high blood pressure and high pulse rate, that's going to give you a bit of a headache. And by doing that, it might also give you some nausea and vomiting as well. Okay? You do not give epinephrine to patients without signs of respiratory compromise or hypotension. Okay? If the patient does not show signs of difficulty breathing, if they're breathing just fine, and it does not look like it does not look like they're going into shock, then do not give them epinephrine. You do not use an EpiPen. You use an EpiPen in a life-threatening situation where there's a life threat and the person can barely breathe. Okay, or they're having a hard time breathing. And patients who do not meet the criteria for a diagnosis of anaphylaxis. Here we go. So, let's do a quick review of the chapter. Okay? Unfortunately, this chapter is not going to take 2 hours to discuss. So, we'll be done in about an hour and 15 minutes. So, review. The signs and symptoms of an allergic reaction are caused by the release of what? Histamines, epinephrine, leukotrienes, or both histamine and leukotrienes. Now remember I told you when a person's in anaphylactic shock, your body creates two chemicals to help fight it. Okay? So it would be answer D, both histamines and leukotrienes. Now this says that the answer is A, but look at the response. It says the 2 chief chemicals released. So I think whoever did this PowerPoint, they meant to put D, which is the correct answer. It is not A. Histamines is a chemical that is created by the body, but it also creates leukotrienes as well. So it's actually A and C, okay? And the answer is D, both histamines and leukotrienes. So whoever did that put the wrong letter in there, but that's not correct. Because you look at this down here, D, both histamine and leukotrienes, that's the correct answer. Okay? Question number 2. The negative effects associated with anaphylactic shock are the result of what? So the negative effects associated with anaphylactic shock are a result. So what causes the negative effects? Is this the severe internal fluid loss? We never talked about fluid loss during the anaphylactic reaction. Inadequate pumping of the heart? I don't ever remember talking about the pump or the heart not working correctly during anaphylactic. Vasodilation and bronchoconstriction. Vasodilation is when the veins and arteries are dilated, and the bronchoconstriction, the airway is constricted. Could it be that? Or D, the nervous system's release of adrenaline. The answer is actually C, vasodilation and bronchoconstriction. Those are the negative effects of anaphylactic shock. So those are bad effects. Having a hard time breathing, the veins and arteries dilated, which they shouldn't have, and that's hurting you. That's causing more harm than anything. But your body thinks it's helping you. Well, actually, it's really not. It's hurting you more than anything. So that's why we get the patient epi. And the epi reverses those two, and it takes the closed off airway, and it relaxes the muscles, and it opens up the airway. And it takes the blood vessels that are dilated, and it constricts them. Okay, so those are the responses for that. Review. You were called to a local baseball park for a 23-year-old man with difficulty breathing. He states that he ate a package of peanuts approximately 30 minutes ago and denies any allergies or past medical history. Your assessment reveals widespread urticaria, which is the rashes, the redness, the itching, tachycardia, which is the heart's racing, and blood pressure. And blood pressure that's only 90/60. Okay? 90/60 is not good. You can hear him wheezing even without a stethoscope. So you can hear, without even using a stethoscope, that you can hear that the patient's having a hard time breathing. So you should be most suspicious of what? Is the person having an asthma attack? Are they having a mild allergic reaction? Are they having a severe, or otherwise known as an anaphylactic reaction? Or are they having a moderate allergic reaction? Which one do you think it is? Probably, I would say, anaphylactic. That's pretty serious. C. The patient's signs and symptoms indicate an anaphylactic reaction, which is a severe reaction. Signs and symptoms of an anaphylactic reaction include difficulty breathing, urticaria, which is hives, over large parts of the body, and signs of shock, difficulty breathing, low blood pressure, altered mental status, okay? Heart's racing too fast or it's going too slow. Certain foods such as shellfish and nuts may result in a relatively slow onset of symptoms, but the symptoms can become just as severe, which I said. Anybody who's had any type of reaction to a food or anything like that, or anybody who's had any type of reaction, and they are scared enough to call 911, they need to go to the hospital, because the symptoms may come on really, really quick, or they may come on slow and slowly get worse over time. Okay? Question number 3. You were called to a local baseball park for a 23-year-old man with difficulty breathing. He states that he ate a package of peanuts. Oh, I just did that one. I'm sorry. Number 4. What is a wheal? Is the wheal a raised, swollen, well-defined area in the skin? Is it an area of localized swelling involving the lips and tongue and larynx? Is it generalized itching and burning that appears as multiple small raised areas on the skin? Or is it an exaggerated immune response to any substance? Which one do you guys think it is? It would be A. Insect stings and bites can cause a wheal, which is a raised, swollen, well-defined area on the skin. There is no specific treatment for these injuries, although applying ice sometimes makes them less irritating. Number 5, you were treating a woman who was stung numerous times by hornets. Ooh. On assessment, you note that some of the stingers are still embedded in her skin. You should what? Leave the stingers in place, scrape the stingers from her skin, or pull the stingers out with tweezers, or cover the stings with tight dressings. Well, let's see. Hornets don't leave their stingers in. Only bees do. You're not going to cover it with tight dressings. Let's see. But if they did mistakenly leave some of the things, what would you do? B. Because of the venom left in the sac located at the end of the stinger, you should not grab the stingers in an attempt to remove them. Instead, scrape them off with a rigid object such as a credit card, business card, or a couple dollar bills folded in half if you don't have a credit card with you. Okay? Number 6. A young male is experiencing signs and symptoms of anaphylactic shock after being stung by a scorpion. His level of consciousness is diminished. His breathing is severely labored. You can hear inspiratory stridor, and his face is cyanotic. Remember, stridor. Stridor is a high-pitched sound when someone is trying to inhale. Not when they're exhaling, but when they're trying to breathe in, you're going to hear a very high-pitched sound. That's called stridor. That signifies that it's an upper airway. The upper part of the airway is swollen. Okay, that's an upper airway blockage. So the patient has prescribed EpiPen auto-injector. What should you do first? So the guy's having a hard time breathing. He's cyanotic. He's got an EpiPen. What do you do first? Do you assist him with administering the epinephrine? Do you apply high-flow oxygen by non-rebreather mask? Do you provide ventilatory assistance with the bag valve mask? In other words, do you breathe for the patient in high-flow O2? Or do you lift his legs and cover him with a warm blanket? Which is sort of treating for shock. But what's the first thing you should do? Remember, life threat, airway or breathing. Oh, I'm sorry, breathing or bleeding. Which one would you do first? C. The patient is not breathing adequately, as noted by his decreased level of consciousness, severely labored breathing, the sound of the stridor, and the cyanosis. And as you know, cyanosis is discoloration around the lips and the fingertips, which signifies poor perfusion. Therefore, you should first assist his ventilations with a BVM, a bag valve mask. He clearly requires epinephrine, but not before restoring adequate breathing first. Regardless of the situation, a patient's airway must be patent and his or her breathing must remain adequate at all times. So ABCs. Airway. Is that airway secure? Yes or no? If it is, great. If not, make it secure. OPA, NPA. Breathing. Start breathing for the patient. Okay? Your partner can breathe for the patient while you get the EpiPen. Question number 7. The most reliable indicator of upper airway swelling during a severe allergic reaction is what? The most reliable indicator. What's going to tell you this person's having a hard time breathing if they're having a severe allergic reaction? Is it the stridor? They're showing anxiety? They have cyanosis? Or they have wheezing? The answer is A, stridor. Stridor is a high-pitched sound that is most common, often heard during inhalation. It indicates swelling of the upper airway. Wheezing, a whistling sound, is caused by narrow bronchioles. It indicates narrowing or swelling of the lower airway. Anxiety and cyanosis can occur from a variety of causes. They are not exclusive to airway swelling. Cyanosis just simply means a person's got poor perfusion. Question number 8. The most common trigger for anaphylaxis is... What's the most common reason that would cause somebody to have an anaphylaxis? Would it be insect stings, chemicals, medications, or food? What do you guys hear more people are allergic to? insect stings, or do you hear more people are allergic to food allergies? It would be D. Food allergies such as shellfish and peanuts, which are the two most common ones. But there are more people out there who have food allergies than allergies to bee stings. Okay, remember I told you guys to help remember that the dosage of EpiPens? The adult EpiPen delivers how much milligrams of epinephrine, and the infant or child system delivers what? Remember I talked to you about the cents? Is it... Now remember, the first one is the adult, so find the one that's the adult. It would be B. 0.3 or 30 cents for the adult and 15 cents for the kids. Number 9. The adult EpiPen system delivers... Did I just go do that? Number 9, question number 9. Oh, okay, I'm sorry. And last but not least, I just gave you guys the answer, sorry. When using an EpiPen, how long do you hold it in place for? You take the EpiPen, you push it up against the skin, you're holding it correctly. How long do you hold it in place for? 5 seconds, 10 seconds, 20 seconds, or 30 seconds? 10 seconds. And that's it. So I hope I was able to explain the chapter to you guys sufficiently enough. I hope everybody is staying safe. The next chapter that I'm going to be reviewing with you guys is going to be chapter 21, which is going to be toxicology. And that's about it. I guess this is going to be an early day for you guys. So you guys take care of yourselves. I'll talk to you again soon. Please, please, please stay safe. Practice your social distancing. If you go outside of the house and you go into a store, something like that, please wear a mask. Okay? Very important. I would love to meet you guys one of these days. Okay? You guys take care of yourselves and stay safe. Bye-bye.